Well, hi everyone. Welcome to another Shop Talk. Today we will be discussing a recent paper, 2024. It was published in PLOS ONE by Dr. Daniel Flowers. The title of the paper is there trustworthy evidence for using manual therapy to treat patients with shoulder dysfunction? And it's a systematic review. Daniel, it's wonderful to have you on our Shop Talk. Do you mind telling us a little bit about yourself? Give us your background and your interest as a researcher.
Sure. So I'm Daniel Flowers. I'm an associate professor at LSU Health in Shreveport in our physical therapy program. I'm also on faculty in our PhD in rehab sciences. And then I'm the program director for our orthopedic residency program. So that's kind of what I do here in Louisiana. Research-wise, kind of my background came in through, I got a PhD at Texas Women's back in 2020. And my initial kind of area of research had to do with gait, biomechanics of gait. But kind of concurrent with that, I was starting to flirt with the systematic review literature before we got into kind of where I've gone now. So, that's kind of my role. My background is started as I still do some biomechanics research. That's still one of the things I do, but systematic reviews as well. And then the day job is really, teaching orthopedics. And I teach introduction to patient care this fall, so teaching new PTs how to put on a gait belt, basics. And then obviously with our orthopedic residents, taking them through, getting ready for specialist certification.
So it sounds like you're in the clinic some still with residency
Yeah, so
program?
I'm academic faculty, but I'm in the clinic about 15% of my time.
That's great. That's great to still have that street cred as you do that. So in your paper, do you mind just mentioning some of the collaborators? Because you had some really solid people, I think.
Yeah, so we had Stephen Schaefer, who's affiliated with University of Hartford, Brian Swanson as well, Sean Riley at Hartford Healthcare, Derek Cluley, who's at Duke, is affiliated with the center, and then myself. So, that was kind of our team. And, this SR is one of a series that we've been doing, but that's the crew, at least for this shoulder SR.
Yeah, like I said, a really solid crew. And I know that the purpose of your paper was to create a trustworthy systematic review. And you also mentioned a living review in the purpose. Do you mind if we start just by you defining what you mean by trustworthy?
So there's a short answer and a long answer. I guess the short answer to what is trustworthy would be, one part of that is, can you verify that the authors basically did what they said they were going to do at the outset? Traditionally, when we talk about trustworthy, it's all kind of on the back end. So looking at p-values and MCIDs and confidence intervals and all that sort of thing. But looking at, when an author gets their IRB, says they've got a protocol, this is their hypothesis, this is their purpose, is that what you get on the back end? The long answer is, like we've already mentioned, this is a series of systematic reviews that all go back to a protocol that was published back in 22. And there, kind of how you quantify trustworthiness kind of followed the thread of prospective registration according to ICMJE guidelines, International Committee of Medical Journal Editors, and then looking at internal and external validity, quality of the research, low risk of bias, and just taking a paper through that chain of events to say, is it prospectively valid? Are you getting what was supposed to come out on the back end, and then measuring validity and reliability and all that on the back end? So operationally, that's the definition, but kind of the nuts and bolts of it is just that simple question of, can you verify original intent?
Awesome. That's a really great definition. And you also use the term living review in your purpose. You mind giving us the definition of what a living review is?
So living would mean the review not ending at publication, essentially. a continual input of new papers. So that the original idea, I wasn't on the team when this first was, come up with several years back, but the original idea was, you get a systematic review and it kind of sits on the bookshelf. You hope people pick it up, but there's not really an update with new information over a period of years. But if you have a living review that, and yes, it's published, but year by year, month by month, as new articles, RCTs that fit the inclusion exclusion criteria for the SR come out, they can automatically be updated. And whenever a substantial change in the recommendations or a change in the quality evidence comes out, you can submit for peer review again and basically renew it. But it's a way of getting around that issue of Flowers et al. Published this systematic review 10 years ago, and there hasn't been an update since we've had these 50 new RCTs.
Yeah, and we were certainly going to house some of these on the CEMMT site so that there was a location for that, and we'll talk about that later. But any recommendation, Daniel, on how frequent, when you all talked about possibly updating these, what was the frequency? What was the cadence of that update?
I believe it was 2 years,
Okay.
but a pretty regular basis. And we can talk about where the plan is now with that based off some of these findings, but that's kind of the original intent, was to just be a continual update.
Yeah, everybody has a plan until they're punched in the face, right? But
Well,
we'll touch on that in a second. So you evaluated manual therapy for the shoulder. And the manual therapy you decided to tackle was spinal manipulative therapy and mobilization. Any reasons why you just selected those two and didn't consider some of the other ones?
again, short and long answer. Short answer is, everyone pretty much agrees those are manual therapy, right? When you get into some of the other things, whether it's soft tissue mobilization, muscle energy techniques, nerve glides, um, dry needling, all those different things, you get some variation. And there's even variation, in the field on what exactly manual therapy is. And so we went with kind of if it's a grade 1 through 5 kind of idea, then we know that's in general agreed upon. And, coming at it, that's coming from the clinical angle, coming from the science angle, it's a way to reduce heterogeneity on the back end, right? So we know that out there, and we go into this a little bit in the introduction of this paper, that the manual therapy definition across the board was highly varied, but everyone included joint mobs manipulation. And so it allows you to kind of see that as kind of the core of the definition is. So that's why that definition was made, or that's why we only included those two types of manual therapy.
Gotcha. All right, we've been dropping breadcrumbs. Why don't you tell us what your systematic review found, including how many papers were included in the final discussion?
So nothing. We found nothing. We found an absence of trustworthy evidence, which I was very disappointed with. I don't have a bone to pick with manual therapy at all. We actually picked shoulder after the two previous SRs as a way to cast a wider net. We did non-radicular C-spine. We did, quantitative sensory testing, thinking, okay, maybe that was too narrow. Maybe that was a bad place to start. Let's go for one of the big two. Let's do shoulder or knee. Surely there's stuff out there for shoulder and knee. So it was really a way to go for one of the big two. At the end of the day, and you can, if you go to our paper and walk through the Prisma diagram, we had 26 that met our inclusion criteria. Of those, only 15 were registered. Okay. Of the 15 that were registered, only 3 were prospectively registered. Again, following ICMJE and ISPJE standards. And it was at that point, I called one of my co-authors. I was like, I got a bad feeling about this. When I saw 15 go down to 3, I got really nervous. And then when you start looking at the rest of the protocol, after prospective registration, we go to Pedro score, we go to risk of bias. We only had one paper get to risk of bias screening, and that paper, was deemed to be high risk of bias. And so at the end, we don't even get to a meta-analysis, much less a discussion on 1 or 2 papers. And so per our operational definition, we had an N of 0.
So I've got so much to say. First of all, I want the people to know systematic reviews have there's a lot of work involved. I think you all looked at 9,126 titles on this and heaps of abstracts. So you cast a very wide net on that. You mentioned that there are 2 others that you've been involved with, and can you tell us what you found on those? Did you find something similar, that basically there weren't very many studies that qualified?
Yes, we've done non-radicular cervical spine pain and the effects of manual therapy on quantitative sensory testing. And we found 3 articles and 1 article in each of those, or I should say RCT, because we're looking specifically at RCTs. So again, after finding 3 and 1, the thought was, okay, let's try shoulder. And I honestly, and if you look at our introduction, if you look at purpose, the way we set it up, we start with saying, a lot of these previous systematic reviews, another one of the variations we saw was some of them will just say shoulder dysfunction or shoulder pain, and other ones zone in on subacromial pain syndrome or phase 2 adhesive capsulitis. And so the way we set it up was, well, we'll do both, right? To cast an even wider net. We'll say shoulder dysfunction, and then we have some exclusion criteria for that. But then, I was confident enough that we were going to find some things that we even said, and then we'll provide separate recommendations per each of these categories. Rotator cuff tendinopathy or subacromial pain syndrome. We can get to a semantics there if we want to. Adhesive capsulitis. So we set it up with the assumption that there's going to be things to put here, and we didn't. So I was disappointed in that regard. But yeah, we were casting a wide net, like you said. We started with 9,000. Once you get past title and abstract screening, we got down to 26, and then at that point, 15 down to 3, down to 1. It got scary quick.
Daniel, can you tell us, you said most of them were either not registered or they were retrospectively registered. Can you tell us why that's a problem?
So just the history of this, back in, I think it was 2005, ICMJ, which is International Committee of Medical Journal Editors, basically said that, in order to verify prospective intent, to be able to read an article and know when I'm reading Flowers et al. Or Cook et al. Or whatever paper, that what I'm reading is a result of what the authors said they were going to do when they wrote the protocol. Okay. Now, there's modifications to protocols all the time, but you can register your modifications to your protocol. That's possible. And so most journals at this point, it's kind of trickled its way down. The International Society of Physical Therapy Journal Editors, I don't think, adopted it until like 2012. But by the time I was graduating with my PhD back in 2020, halfway through my PhD, professors were like, you got to prospectively register. You got to register your article, because I can't think of a PT journal that doesn't require prospective registration prior to the recruitment of the first participant. And they don't limit this to RCTs. They require this for all clinical trials. So if it's human subjects research with a health-related intervention with a health-related outcome, you need to prospectively register. That way, when you say, this is our hypothesis, this is what we're going to do, this is our power analysis, on the back end, we can read the paper and know you stayed married to that and that you're reporting accurately.
Yeah, it reduces selective reporting big time, and certainly retrospective allows a person to register their information toward what they're finding in their study. You also mentioned in your paper that a lot of the studies did not have primary outcomes, that they basically threw spaghetti on the wall and had a number of different outcomes, and they didn't really outline which was the primary. Can you tell us why that might be important?
Well, typically your primary outcome is what your study should be powered for. So when you do your a priori power analysis, right, you've decided, these are our outcomes, but outcome X is the effect size. We're gonna use an effect size for outcome X, whether it's VAS or NPRS or gait speed or forward step down test, whatever it is, and you're going to power your whole investigation off of that. And your primary hypotheses are going to be related to that, right? If you don't have that, if you don't have a primary outcome, the question becomes how are you powering your study? But then if there's not some sort of hierarchical organization to what outcomes we're looking for, it makes it look like you don't have a priori hypotheses, right, in a hierarchical organization. You have primary analyses or primary hypotheses and secondary analyses and secondary hypotheses. And so the concern is, there's a learning curve for all of us, so no one's innocent here. But, early researchers, they say, oh, we're going to look at these 10 things. And on the back end, if you find something that's significant, oh, well, that's the one we were worried about. Well, you kind of need to say that on the front end. And so if there's not a primary outcome specifically named, it's hard to know, what the original intent was. One thing we've seen, and we talk about two cases of this in this paper, is, the registration saying the primary outcome is this, but then the paper saying the primary outcome is that. So you've got the registry saying X, paper saying Y, and then the paper is vague on how they did their power analysis, and it kind of leaves us unsure. And because we're unsure, it's not verifiable, which means it's kicked out.
It's not trustworthy.
Correct.
Exactly. So, Daniel, you read a lot of papers. Is this an indictment against manual therapy research or an indictment against physical therapy research? Or would you expect similar findings maybe in the exercise world or in other interventions? What are your thoughts?
We're not picking on manual therapy. my concern is this is I think we can do better as a profession, right? So I'm as shocked as everybody. Okay, I really didn't expect this. Like I said, on the front end, I was thinking, let's do shoulder because it'll fare better. Honestly, I don't think this is, this one paper wasn't even about manual therapy. This one paper was about manual therapy for a given joint with a given definition of shoulder dysfunction and with a given definition of manual therapy. But you could say that about every systematic review. You could say that about every RCT, right? However, there's other papers that have reported the rates of retrospective registration and selective outcome reporting and untrustworthy effects. And this is not a trend that's unique to PT. We outline some of the, when you don't have any papers to discuss, your discussion takes a different route. And our paper does this. And we outline how the medical research, we talk about anesthesia, we talk about other examples, are seeing similar issues. And so I don't think it's an indictment of manual therapy. I don't think it's even just an indictment of PT. I think healthcare research in general, and in addition to that, we've set standards. We said back in 2012 these were the standards we were going to follow, and our inclusion criteria doesn't go all the way back because we want to be fair. We want to say, okay, well, these standards were adopted in 2005, adopted by ISPJE in 2012. So we're not even going to start looking before 2010, right? You can't pick on people for a rule they didn't know about, myself included. But if we're still seeing an issue and we've said these are the standards, we as a profession either have to change our standards or we have to follow the standards that we've set. And that's a discussion we all need to have. I think it's important to remember this paper is about the quality of the evidence that we have. We're not talking about what the evidence we kicked out says. We're talking about how much trustworthy evidence we have. And the answer to that is none.
That is super important. I think what you just mentioned there, you're not condemning the evidence. You're condemning the quality and the trustworthiness of the way it was reported and the way that it ended up in dissemination. I think that's really critical. But you also bring something up. There are other systematic reviews and meta-analyses who will report some of these things, but they still create these forest plots and make recommendations on the literature. I mean, how do you feel about that? Yeah, but you ended up with 0, and they may end up with 26 and then turn around and say, here's what you should do.
It's a mixed bag. And again, we kind of outlined some of what we found. There are systematic reviews where they've done exactly what you've just said, where, despite high risk of bias or despite having to downgrade their quality on the grade, they'll make recommendations and then they'll say, but follow these recommendations with caution. In which case you need to ask, why make recommendations? Okay. Other people, other studies, other systematic reviews have been careful, and they've only based the recommendations off of the studies that they've included that have low risk of bias, don't need to downgrade. Pile on top of that, shoulder dysfunction means something different to everybody, and manual therapy means something different to a lot of people. And so I don't know what to call that other than a mixed bag, right? I would say, if we could work on some of our definitions, some of our terminology, that would help. And then if we would just stick to the standards we say we follow, that would help as well.
So very wise suggestions there. And I have to ask you, you're currently a residency director. You teach in a DPT program. You're a board certified physical therapist. Do you use manual therapy on the shoulder? Would you use it? Or, I mean, how do you take this information based on everything you've read and what you've summarized? With that person that's in front of you on a Monday, how do you address that?
So we do teach manual therapy in our residency program. We have a fellow that teaches our manual therapy course. This paper doesn't provide high quality evidence either for or against. We recommend, there is no high quality evidence to recommend for or against the use of manual therapy in the shoulders. Where does that leave you? It leaves you the same place we are in other areas of the profession where we don't have a solid answer. And so in those cases, what do? I use manual therapy as an adjunct in patients with shoulder dysfunction, right? I don't have high quality evidence that says if I do this, it's going to cure anything that's going on. And I don't have high quality evidence to tell me not to. But it's important that I know I don't have high quality evidence either way. And that puts me in a different situation than having evidence that says for or against. You'll see this in our clinical practice guidelines, and that's what the grading system is in our clinical practice guidelines. There are times in our CPGs they will say, thou shalt do this, and they say, thou shalt not. And then there's other times where they say, I don't know, balance this with everything else that's going on. Yes, I practice manual therapy, but I use it with a comprehensive, treatment plan. but it's important for me to know the state of the evidence, which is we don't have really good evidence.
So I have to ask you this because I loved your discussion. In the discussion, you actually seem to debate this idea that are we being too strict with the way that we're defining trustworthiness? Are we setting the bar so high that nobody could ever meet it? I mean, what are your thoughts on that? Certainly registration, like that's fixable. But what about some of the other components?
Right. So, you know, we have had that discussion, and I've thought about that a lot. I think our discussion kind of does that. Are we too strict, or are we not being strict enough? And kind of the basis we use for both of those are what, again, we didn't come up with these standards. Okay, we're just applying the standards. And I've said it to my co-authors 3, 4, 5 times now that at some point I want to title one of these papers "Don't Shoot the Messenger," because all we're doing is, if we have said as a profession we're going to require X, Y, Z, and in order for your RCT to be published, we want it to be low risk of bias and have good validity, internal, external, all these things, then we have to mean it. And that's the only bar we have set. The bar we've set is, if the guide to authors says you're going to prospectively register and you're going to follow that you do it. And all we've added to that is a Pedro score and a risk of bias assessment. And I don't think that's a high bar. When you're left with 0, well, that kind of answers another question. I won't get too far into that. As far as, are we not being strict enough? There's a lot of, that's what journals are requiring right now, and it's kind of shaky about whether we're following that. There's discussions, I'm sure other people have heard about it, of one day getting to the point where not only do you send your manuscript and your trial registration, but we want your data set. And there's, we talk about this at LSU, our research office is setting up data repositories and everything else for us to start submitting our entire SPSS data file. We're not even getting that far, right? We didn't even get to the end of our current protocol. And if there's discussions in the field of going beyond that, then I don't think we're being too strict. And if we keep setting the bar higher and we keep not meeting the bar, eventually we're going to get to where the standards are unattainable for ourselves. And so I think as a profession, what we have to decide is, are we going to admit that we have a problem and try to meet the standard we've set for ourselves? Or are we going to lower the standards we've set for ourselves? And I have an opinion on what we should do, but I think that's where we're at.
You know, sharing data is not easy at these institutions, and I think that's going to be a hard nut to crack when we have to go there. Just a couple more questions, if you don't mind. What'd you learn from this? I mean, what was your biggest? You've done 3 of them now. What in 2 sentences? What's the biggest things you learned from this?
It's the same lifelong learning thing that we all heard in PT school. You're not done learning when you graduate, right? And I think it's important for us as a profession to admit that we're all still learning, even our expert researchers. And whether you're a full professor who's been, researching 40 years or a new junior faculty member, we're all still learning how to generate and effectively report high quality research. And we clearly haven't mastered this as a profession. It's something we can all learn together. I think that's what I
really
took.
well put. So Daniel, I think I've worked on some of these with Sean Riley. You've worked on all of these with Sean Riley. Sean is former sergeant in the Army. Can you say one nice thing about Sean for this podcast? Just one.
He's one of the most driven people I've ever met. He is a good friend and a good man, and he is so determined. The people I work with,
Sean is trustworthy.
he's
sure.
trustworthy. He is very trustworthy. I know if I say something to Sean, it's going to stay between me and him, and that's, this day and age, that's that's few and far between. So good man.
Good man. All right, finish it up with telling us what you're working on now. What project? Because I think you're done with the trustworthy reviews, right?
Yeah.
And
I
so
think we
what are you working on now?
there's a couple, like I mentioned earlier, I've got a couple of lines of things we're looking at. So related to this, seeing what happens with heterogeneity in relation to this protocol. Um, there's some evidence from other medical literature that uh, there's a natural experiment basically that happened back in 2000 when the National Heart, Lung, and Lymph Institute, I think is what it was called, started requiring prospective registration, or otherwise you couldn't get funds. And so there was a hard stop. And what they found was heterogeneity and rejection of the null flatlined just from prospective registration. And so the question is, well, how, we haven't been tracking heterogeneity as we've been doing these. What happens if we do? And then another big line of research right now is still the biomechanics. We've been doing a lot of at-home hip activation or at-home core stabilization and balance and all that sort of stuff. And it's also how we're trying to get our DPT students involved in research, trying to start a pipeline into PhD work for students to fill some of these faculty vacancies we've got, and then spend a lot of time recruiting for our residency. So if anybody wants to do a residency, holler at me.
Awesome. Daniel, thanks so much for sharing your knowledge with us and for being on our shop talk. I really enjoyed it. Best of luck to you.
Thank you, sir.